All right, everyone, we'll get started now. Welcome, everyone, to University Hospital's Department of Medicine Grand Rounds. The CME code for today is 46452. It's my pleasure to introduce Dr. Remy. Dr. Remy is a tenure-track associate professor and NIH-funded physician scientist in the Departments of Internal Medicine, Pediatrics, Pathology, and Biochemistry, and is also a tenure-track associate professor in the divisions of Pulmonary Critical Care and Pediatric Critical Care Medicine. He serves as the director of the Division of Pulmonary Critical Care Medicine, Basic Science, and Translational Critical Care Research, and co-director for Clinical Basic Science and Translational Critical Care Research in the Division of Pediatric Critical Care Medicine. Dr. Remy holds a medical degree from Jefferson Medical College, and he has master's degrees from both Duke University and Washington University in clinical research and translational research, respectively, with an immunology focus. He completed his dual residencies in internal medicine and pediatrics here at Case Western and Rainbow Babies and Children's Hospital. He achieved his Pediatric Critical Care Fellowship at New York Presbyterian Hospital, Columbia University in New York City, and Adult Critical Care Fellowship at the National Institutes of Health in Bethesda, Maryland. He's quadruple boarded in each of these specialties. Following his training, Dr. Remy was associate professor at Washington University in St. Louis in departments of pediatrics and internal medicine. In addition to his extensive experience in clinical care of patients with COVID-19, Dr. Remy is an international expert in adult and pediatric sepsis, COVID-19 disease, and global health. As an adult and pediatric critical care physician, his laboratory is focused on two areas: heme-based trafficking and signaling and immune dysregulation in context of diseases of intravascular hemolysis, and after red blood cell transfusion, and real-time immunophenotyping of pro- and hypo-inflammatory states to identify timing for immunoadjuvant therapies. Dr. Remy sits on a number of national and international task forces in sepsis and COVID, and with that, it's my pleasure to introduce him today for his Grand Rounds discussion, from hemolysis to distancing, from a storm of cytokines to exhaustion of immunity, SARS-CoV-2 pandemic lessons learned from sepsis.
Thank you. Thank you, and thank you very much for the opportunity to speak today. I hope there's a bunch of people in TV land listening intently, and I hope to at least talk to you guys today about a little bit of work of what my journeys look like. It may seem circuitous, although for me it's not. It tells a story, and I'm excited to tell it. So, I have no financial disclosures. I do have a number of patents related to some of the work that I'm talking about today, namely the use of our ELISpot platform. These are the objectives which you have. So today I hope to take you through my journey from understanding the risks of stored red blood cells to the mechanisms of storage lesion, and then understand a little bit about heme-based signaling and immune dysregulation, and then where I hope my lab's future will go. And this includes some of the work that we've taken from human studies to canine studies, to human in vitro studies, back to the mouse, and then back to human in vitro studies. And in this process, I was always taught by my mentors to establish your research career based with these tenets: evaluate a potential problem, demonstrate a disturbance, hone in on a molecular disruption, modulate in animal studies after you've developed targeted targets after refining mechanistic and signaling pathways, and then conduct a clinical trial. So let's talk about sepsis. I love sepsis. So if you're on rounds with me, you know I'm going to talk a lot about sepsis. So sepsis is a serious worldwide threat. Worldwide, it affects and kills more than 11 million people. And if you think about what happens, a pathogen from an infection induces a host immune response. Namely, there's two divergent responses going on in the host, including an anti-inflammatory one as well as a pro-inflammatory one. This subsequently induces a cascade that causes endothelial dysfunction, microvascular blood flow redistribution, and then alterations in hemostasis and coagulation. Many of these disruptions of homeostasis that we see in sepsis are very similar to something that's currently been going on for the last 20 months, and we'll touch a little bit upon that. And just for clarity, and why I love this disease so much is because I hate this disease, because it kills one person every 3.5 seconds. So by the end of this talk, too many people in this world have lost their lives to this horrible syndrome. And as mentioned, sepsis is unique. It's got two divergent host immune responses going on. You've got one of this pro-inflammatory state, and then subsequently a protracted immune suppression. And when you think about the immune suppression component, as you can see here from this schematic, is that when you get dampened release of pro-inflammatory cytokines to monocytes, you get a response, in response to a danger-associated molecular pattern, you get this immunosuppressive phenomenon. But this is what's been really challenging in sepsis. What determines death? You've got multiple host and pathogen factors and some patients dying very early during the hyperimmune state, where others are dying during the hypoimmune state. What delineates who's going to die? Understanding that is going to be key and fundamental as we move forward. And over the last 50 years, our tenets of management really haven't changed. Early recognition, correct antibiotics ASAP. So 2007, we learned the earlier antibiotic administration improves outcomes when time from hypotension. Rapid fluid resuscitation to restore tissue perfusion, judicious use of vasopressors, and prompt removal of source. These have been the therapies. You notice none of these are actually targeted at the immune system. These are all just supportive care. And in fact, in the first derivations of the sepsis guidelines over 20 years ago now, red blood cells were included as in transfusion because they were posited to improve oxygen delivery and restore tissue perfusion. So let's talk a little bit about blood transfusion. So approximately 35 units in the United States are given every single day of red blood cells. Nearly 21 million blood components are transfused each year, and about 50% of all ICU patients will receive more than one unit during their hospital stay. And what we know from multiple studies is that mortality increases with the number of transfused units of red blood cells. So the question becomes, could red blood cell transfusion be contributing to mortality? Or does the length of the storage of red blood cells that are transfused influence outcome? And you're probably asking, what does that mean, the length that they're stored? Well, if I offered you a Twinkie at the end of its shelf life 10,000 years from now, or one that just came off of the actual assembly line, I would argue you would want that fresh Twinkie. However, you still, within the guidelines of what the FDA says, could eat that Twinkie at 10,000 years from now because it's still, quote unquote, within its expiration time frame. Well, red blood cells in the United States are also governed by the FDA, and the gold standard requires that 3/4 of these cells remain in circulation after 24 hours, and hemolysis does not exceed 1% in the bag. Yet some studies have demonstrated that as red blood cells age, there's toxicity. And these are just a couple of them that discusses different parameters for that. So what happens when you put a bag of blood in a refrigerator at 4 degrees? You get refrigerator RBC storage lesions, which include metabolic derangements, changes in shape, accumulation of plasticizers, potassium, changes in oxidative lipids, in injury to lipids and proteins, loss of membrane carbohydrates. And this is what the red blood cell looks like. So, do you want that Twinkie at the 10,000 day, or do you want it on that fresh first day? So one of my mentors at the NIH, Chuck Natanson, when we began to embark upon this field, always starts with looking at what the current level of evidence tells us. And so conducted a meta-analysis, and for the residents, you can see here the no effect line is at 0, middle line. To the right favors use of younger blood. To the left favors older stored blood. And you're looking at mortality across a number of studies. And in this study, we published, and we did a subsequent revised one in 2016 that I was fortunate to be part of. You can see that younger blood has improved outcomes. So now we took this data and said, well, we want to explore this, at least in a large animal model, because that's what we do. And so we use a canine experimental sepsis model, which we've been using since the early 1980s with a carefully curated Staph aureus genotyped bug that I go in, I put into the left lung field, use of a bronchoscopy. We have a dog ICU where we monitor these dogs for 5 days. We have staff around the clock. There are no work hour restrictions. The dogs also don't complain, and there are no code violates. But we use our program for 96 days for these canines. We induce sepsis at time 0 by instilling that Staph aureus. And we use vasopressors. We have an arterial line in place. We've got a central venous line in place, a PA catheter. And then I also provide the canine with a tracheostomy when they're placed on a mechanical ventilation. Very similar to what we do in humans. There's stress ulcer prophylaxis and DVT prophylaxis. And so in this vein, we wanted to examine use of old blood, 7-day-old versus 42-day-old blood, which would be the limit for what the FDA allows for storage, 42 days. So we challenge our animals with that Staph aureus, and then we provide them dog-matched blood. So they need to have 2 type-in screens per UH policy, at least for dogs. And we replace 70% of the blood volume, and we transfuse them 4 times with either 7-day-old blood or 42-day-old blood. And look what we found. You're looking at survival. In the top line is transfusion of 7-day-old blood in sepsis. And you had about a 70% survival. And not a single dog lived that received 42-day-old blood. Identical experiment across the board, but something in the bag was leading towards that demise. We also looked at the shock scores. So what happened to the blood pressure in these animals and how much vasopressor did they require? And as you can see here in yellow, difficult to see, yellow is going to be 7-day-old transfused blood, blue is going to be 42-day-old blood, and above you're going to see a small panel that looks at what happened during the transfusions. But over 48 hours, 42-day-old blood had worsened hypotension. But during each transfusion, the dogs are actually hypertensive with that blood, which made us start looking at some other modifiers of what happens with these hemolytic processes, including free hemoglobin from a red blood cell as it unbounds and circulates in the plasma. You can see here we've got logarithmic differences in plasma cell-free hemoglobin. And in the same vein, we have logarithmic differences in the plasma nitric oxide consumption capability. This could help explain why the dogs, while getting the transfusion specifically, were having hypertension up front. And then we decided, well, you know, what happens if you just give blood to the dogs, 42-day-old blood in these large quantities, and don't actually include an infection? Well, to do that experiment, you see 4 panels here, and what you see at the top upper left is no bacteria instilled into the animal. The bottom is a very large whopping dose of bacteria, and then panels B and C, you've got 2 different doses of bacteria, and then we transfuse these animals 7 versus 42-day-old blood. If you make them really sick, they all die. Doesn't matter if you give 7 or 42-day-old blood. If you give no bacteria, nobody dies. In fact, old blood by itself is not going to cause mortality here. And then as you can see, as you start to ramp up your bacterial infection, you clearly have an increase in mortality. And so the increased risks of older stored blood is dependent on the presence of established infection. And this was outstanding work that Irene Cortez-Pugh at the NIH and our group did during that and published on it. So let's talk a little bit about hemolysis. So a ruptured red blood cell will then, as you can see here, it's got 4 hemes attached to its hemoglobin group. As this circulates in the plasma, there's got to be a natural homeostatic mechanism to be able to scavenge that. And there is, in fact, haptoglobin. So haptoglobin will scavenge that free hemoglobin and then bring CD163 to move this from intravascular to extravascular spaces via macrophage and then for further degradation versus the reticuloendothelial system. But as you've exhausted those stores of haptoglobin, or you've got whopping amounts of this cell-free hemoglobin, this undergoes further oxidation, releases heme groups, and the body has a homeostatic mechanism to scavenge that via hemopexan, another protein, which then circulates with complexes with CD91 to then go through heme oxygenase enzymatic degradation to carbon monoxide, iron, and biliverdin. And then excess heme, even above all of that, can bind to albumin, lipoproteins, and other transporters, and certainly can have deleterious effects. So I became really interested in, well, is there a way that we could actually scavenge all of this circulating plasma-free hemoglobin? Maybe we can alter outcomes. And to do this, we first decided to say, let's do this in our sepsis model with exchange transfusion, but let's also give haptoglobin without giving any extra blood, because sepsis by itself has intravascular hemolysis. Let's compare the two. And what we found in giving human haptoglobin into these canines was that haptoglobin was able to improve survival when we use our exchange transfusion model, but more importantly, it actually improved outcomes with patients, or with our dogs with just sepsis alone. And then when you looked at the physiologic disturbances, haptoglobin was able to quench that cell-free hemoglobin alterations, as well as decrease the amount of that circulating non-transferrin-bound iron. So I became really interested again and said, well, I want to know more about what happens now one step further when you move from cell-free hemoglobin to oxidized heme. Because we do know that with red blood cell lysis in observational studies, patients that have increased cell-free hemoglobin, decreased haptoglobin, and then decreased hemopexan levels, as done by one study, have an increased mortality, but also they have an increased risk for development of nosocomial infections. And let me just give some historical context to that. Back in the 1960s and 1970s, with canine experiments with renal allografts, they found that if you gave 1 unit of pack cells to that dog, or in humans, you actually reduced rejection. There's something immunosuppressive in the blood. And that doctors were savvy in the 1970s and said, well, I'm going to give a transfusion to reduce rejection for my organ transplant. And this continued all the way to the early 1980s, at which point our AIDS epidemic basically stopped that practice with better immune suppressants on the market by that point. But up to this point, people haven't really further examined why there's this immune dysregulation with what's going on in that red blood cell bag. And some other studies have demonstrated that nosocomial infections are certainly increased with red blood cell transfusions. So to take a step back for our trainees in the room, you all are familiar with the innate and adaptive immune system, 2 different systems that help protect us. In the skin, we have physical barriers that help us. We've got phagocytic activity with monocytes and macrophages, neutrophils, and K cells. And then our adaptive system, which has our T cell killing capabilities, as well as our B cell memory, our B cell, clonal B cells, and our memory B cells that allow an antibody response. With our innate immune system, these are stimulated either by a pattern or a danger-associated molecular pattern that induces the subsequent downstream effects. We're going to talk about innate and adaptive markers. But for the purposes of this talk, we'll talk about this in the context of TNF-alpha as a marker of an innate immune system functionality, and adaptive will be interferon gamma. So this was a study that I stumbled upon in 2007 as I was relocating to Washington University. And I thought it was really interesting because I was starting to look at the sort of in between what happens after cell-free hemoglobin all the way to the iron stage. And this study looked at peritoneal macrophages in mice, not in sepsis, but just looked at the influence of heme, 20 micromolars, taken with ex vivo, stimulated peritoneal macrophages, and demonstrated that heme, in isolation, increased TNF-alpha secretion. They went on further to demonstrate that this was independent of the TLR4 activity that we see with lipopolysaccharide. But it demonstrated that heme, in isolation, had a pro-inflammatory effect. And it started me to get thinking. The largest organ you have in your body is your red blood cells. You've got more red blood cells. So clearly your red blood cells aren't killing you because we'd all have difficulties every time we were faced with a certain illness. But there may be certain contextual experiences that can lead towards deleterious effects. And it's possible that in some patients that have repetitive heme stimulation or circulating heme, that perhaps they have some immune dysregulation. And so I posited at that point that circulating heme, acting like a danger-associated molecular pattern, could induce immune paralysis, not pro-inflammation, but repetitive heme stimulation could actually paralyze the immune system via repetitive TLR4 activation, and this could be dependent on both the timing of that and the quantity of heme that was bioavailable and had bioactivity. And to be able to get there, these were my specific aims. I first needed to understand what happens with red blood cells during sepsis with heme processing. I wanted to characterize that effect on monocytes, as well as I've expanded to macrophages and lymphocytes. And then I wanted to look at some tractable mechanisms like heme oxygenase 1 and TLR4 signaling. And so this was the focus of where I took my research at WashU. And I looked at 3 different ways to evaluate this. I had an in vitro model where I looked at just human cells from healthy volunteers. I had an animal model with mice. And then I was conducting a children's clinical trial where we did an observational study and looked at patient samples as well as adult samples with sepsis and non-sepsis. But the first thing I needed to do is recapitulate what that group in Brazil did with demonstrating that heme in isolation causes TNF-alpha secretion. And we did that. So what you're looking at here is negative control, lipopolysaccharide. This is a simple ELISA for TNF-alpha. You can see, this is not surprising, that LPS would cause a TNF-alpha response. And heme at 20 micromolar had also, not as robust, but had a similar response for TNF-alpha secretion. So at least my lab that I just started at least could do the same thing that other labs could do. But then we did something different. We took, this is 5 volunteers, we took their whole blood, we decided to lyse a fair amount of each individual person's blood, re-put it back into different alloquats of 0 to 100% red blood cell lysis. And then what I wanted to do is evaluate their TNF-alpha ELISA production after stimulation with LPS. So if I give you LPS and you have no hemolysis, your numbers should shoot through the roof, right? And so what you see here is as we cause lysis, what you're looking at percent lysis, this is total heme. We increase the amount of heme certainly in each of the samples. That would be not unexpected. This is negative control. Obviously, there's no LPS here, but this is 0% lysis, and you can see the TNF-alpha response with just giving LPS. But look what happens when I give LPS against all of these different alloquats of hemolysis. You blunt the LPS response. So now I've induced a pro-inflammatory state within this dish and blunted it by just giving lysed red blood cells. So this was fascinating to me because it made me start thinking at least about some of the work that we're going to embark upon. So Dan Mannion in my lab decided to look at this in adult patients with sepsis. And so I'm going to take you through this busy slide. But what you're looking at here is an LE spot plate, 96 wells. What we look at this plate is we stimulate these cells, PBMCs or lymphocytes, against a positive stimulus, LPS for TNF-alpha production, against CD3, CD28 for interferon gamma production. And in the plate, you can actually see the cells that are producing that cytokine of interest, and the size and number of cells tells you the robustness of that exact response. So if you're not actually producing it, you're going to have no spots. And so as you can see here, these are a number of spots. Then I can further go even further and evaluate these samples with heme or other potential therapies. And if I get more numbers of spots on this well, that would demonstrate an increased response, or I could potentially decrease or dampen the response. And so what we did here is this is healthy TNF-alpha, healthy volunteer, septic TNF-alpha, adults with sepsis, healthy interferon gamma, healthy volunteers. This is septic interferon gamma. And what you can see here at the bottom x-axis is in every single plot, you'll see negative control, positive control, that should delineate that positive response, and then 5 micromolar, 25, 50, and 100 micromolar of heme co-incubated in each of those wells. And across the board, septic adults versus healthy adults. As you increase the amount of heme, you actually cause suppression of TNF-alpha production as well as interferon gamma production. And when you look at the cell viability, because what you really want to know is, am I killing the cells? The cells weren't dead. They just weren't making those. You actually paralyzed your innate and adaptive immune cells. This was really exciting. And so this is currently being worked up for publication, but now I wanted to move into the animal. And so we use a cecal ligation and puncture model. So we take out the cecum, we tie it off, we poke holes in it, we allow for that to exude and cause a peritonitis and cause polymicrobial sepsis. But before I could do that, I first needed to demonstrate, even before sepsis, that if I gave 500 micromolar, 200 micromolar, 100 micromolar, 50 and 25 and 10, so normally in physiologic conditions, you have anywhere from 1 through 100 micromolar, depending on if you got malaria or sickle cell disease or intravascular hemolysis and sepsis or trauma, and then 500 is super therapeutic. No dose of heme killed these mice. So remember that canine study where I showed you that you actually had to have an infection? Same thing with heme. Didn't cause any damage to these animals. They were robust as can be. But look what happened when I put those same doses of heme into our sepsis model for mice. So black is going to be a 50% survival, all doses of heme, given at 6 and 24 hours, induced death. Something causing paralysis of the immune system. Next, we try to give hemopexan. So in the dogs I gave haptoglobin, I took it one step further. Now I gave hemopexan to try to scavenge that heme. And this is also quite interesting. In red, you see heme causing 100% lethality. In purple, you see the control, the hemopexan plus heme. I was actually able to restore survival from death of 100% to about 40% death. But more importantly, hemopexan, even without heme on board in green, had an improved survival in sepsis, much like we saw in haptoglobin. So now going forward, I've got 2 potential therapies that could be used potentially in humans. And then we looked at more immune findings in these mice, and we gave heme at 6 and 24 hours, and then later in their sepsis course at 24 and 72 hours. And much like our adult studies, we demonstrated that in the animals, they had the same immune suppression. This is great because now we've got a human and animal model that show the same thing. We've got ex vivo and in vivo data. And then we tried to use a TLR4 knockout, if you will, with a C3HEJ. And we found that heme also induced worsened survival. And it wasn't because of TLR4 pathway effects. And so based on all of this, I got really excited. I got descriptive findings. I'm getting ready to move towards writing my R01. But what I really needed to know is what is the context which with these findings are relevant? What are the cell signaling pathways responding for this immunosuppressive pathways? What are they? Are the STAT pathways MyD80, TLR4 pathways, JAK stats? Why were the mice dying? Was it making the infection worse? And then how does heme circulate through the body? Does it scavenge with certain vehicles that actually have worse deleterious effects and others are protective? And could we modulate these and develop targeted therapies? Really great questions I was super excited to ask, and this darn thing strikes, COVID-19. And so as we got there in January, February, as an immunologist, this was exciting also because my lab was sent home. I was obviously taking care of COVID patients, and a lot of the data was coming out of the Wuhan cohort and multiple publications. And I started to get really excited for a different reason. So what was interesting was that in these patients, the most common laboratory abnormality was depressed total lymphocytes, lymphopenia, immunosuppression, very similar to what I was just looking at. And also, if you look at those that died versus those that survived, those that died had absolute lymphocyte counts less than 1,000 throughout their time course with the disease and ultimately their demise. But those that had an ALC above that seemingly survived. And these patients that did not survive had started to have a spike in their neutrophil counts at days 5 to 7. This is well before we started using dexamethasone. This is in the patients that really were at this point, we're only getting, some of them getting hydroxychloroquine and some other potential therapies, but that's about it. And when you looked at a number of other studies, 50% of these patients had secondary infection. If your immune cells are exhausted, you are predisposed to getting secondary infections. We see this in sepsis. It seemingly was happening to some degree in COVID. But this is all I kept hearing about on the news. There's a cytokine storm, cytokine storm, cytokine storm, the storm of cytokines. Everything is high. We've got to reduce that. But cytokine storm don't always actually agree with an immune suppression. But if you remember in sepsis, you've got these divergent immune states. And so severe lymphopenia also occurs in sepsis and is also found with increased mortality, but it stimulated me to want to go further. So what I did at that point is I got a team together at WashU. We decided we were going to study all these. Even though we're taking care of patients, why don't we grab samples, run them to our labs, try to run them in real time? And then we expanded to having 5 different sites in the country, and we would do lots of various things. And I worked 73 days in a row in our COVID ICU, taking care of COVID patients en masse and running around different samples, and then certainly talking on different Zooms all across the world because this was an area that was well within my wheelhouse. And so myself and Richard Hotchkiss and a bunch of other folks were really excited about this because we wanted to understand the why. And thankfully, we had enough patients at one point that we could explain at least some of the same findings that were seen and some new ones. So we did this study looking at COVID ICU patients, but we compared them to sepsis ICU patients and patients that were in the ICU that weren't septic and healthy volunteers. And what you can see here is that we demonstrate the same thing that came out of the Wuhan cohort with our own St. Louis and Florida cohorts, which is that those that died had absolute lymphocyte counts less than 1,000. Those that lived certainly had higher absolute lymphocyte counts. And you can see that predominantly most patients died within the first, if you will, 2.5 to 3 weeks. So we found that prolonged lymphopenia was associated with mortality. But this is where it got really interesting. We did find that interleukin-6 in isolation was associated with 2 times higher than our septic patients. Now you're looking at LE spot findings. So when I give spot number, remember that dish that tells you that cytokine? And so this is going to be interferon gamma or interleukin-6 or TNF-alpha. And so this is COVID over time, days 1 through 15 versus septic patients. Red dots are going to be non-survivors, black dots are survivors. And when you compare these 2 cohorts, 2 times higher in our COVID patients. But this is what was novel, and we were proud to be the first in the world to really demonstrate this and publish in JCI Insight in this, which is that when you compared COVID patients, they didn't produce interferon gamma. Their adaptive immune cell, their lymphocytes were exhausted, paralyzed. And you can see here, as compared to septic patients and critically ill non-septic patients, they're quite suppressed with T cell function. And then when you looked and compared their interferon gamma and their TNF-alpha, across the board, their TNF-alpha production was depressed. They had immune paralysis. Didn't jive quite well that this is just an isolated cytokine storm. There was more going on. And when you looked over time, non-survivors, minus a single time point that raised here, had this problem with interferon gamma production and TNF-alpha production to the end of their lives, as compared to those that survived in black. Ali Elabadi, a member of our group as well, Ali and a number of other folks worked with us at the same time. He compared our findings, and what he looked at was different cell types with CD4, CD8 T cells and plasmablasts and B cells, and compared it to his area of interest, which was influenza, and found that this COVID-2 suppression was similar to influenza, but more robust. So really interesting. Then Phil Mudd, who's also part of the group, and works with Ali Elabadi and Mike Diamond and others at WashU, then went on to do some single gene analysis and found that there were differences in the relative abundance of transcriptional activity of all cell subtypes across these conditions, but more profound seen in COVID disease. And then Isaiah Turnbull, another member of our group, took the data and then compared severity of illness with COVID, moderate versus severe, and wanted to do mass cytometry. And this paper is being published right now in Science Advances. And he looked at COVID across all of our patients to look at certain phosphoprotein signaling pathways. He also did some work in looking at interleukin-6, interleukin-8, and found that severity correlated specifically with those alterations. But this is what was most exciting from his work. So he looked at 5 cell populations and 15 different phosphoproteins. You're looking at some of those signaling pathways. And as he looked across those pathways, it was STAT3 that was the predominant signaling pathway activated by COVID-19. Now, for those that are not excited like I am of immunology, you're like, who cares, STAT3, STAT1, I don't really care. Well, STAT3 is important because it sits at the intersection of inflammation and innate antiviral immunity. In fact, STAT3 inhibits type 1 interferon responses, and then type 1 interferon signatures are dramatically repressed in peripheral blood leukocytes of critically ill patients with COVID-19. When you looked at STAT3 knockout mice, they have defects in bacterial clearance during their bacterial sepsis. Think about that. If you've got a defect in STAT3, you've got difficulty clearing bacteria. Think about that with a virus that you have difficulty clearing from your lungs, that having persistent, ongoing tachypnea and ARDS. And furthermore, pharmacologic inhibition of STAT3 attenuates inflammatory cytokine production during sepsis and is associated with improved survival. So blocking STAT3 improves survival. We correlated STAT3 negatively with our interferon gamma production, which is fantastic because there was definitely a change in severity of illness with these findings. But this is what's most exciting. Who's ordered baricitinib before in their patients? Now you got a reason why. Pharmacologic inhibition of STAT3, remember, attenuates inflammatory cytokine production during sepsis. Well, baricitinib is a JAK inhibitor. And JAK inhibitors, as you can see here, inhibit STAT3. You come first full circle. You will look at the disease, you try to have a mechanistic understanding, you develop targeted approaches, and it starts to make sense. So we're excited that this patient paper that we submitted, not only in Science, is being submitted right now to Nature because it explains why in certain patients baricitinib may be helpful. And then other groups have gone on further to demonstrate T-cell exhaustion and lymphocyte depletion, which is great because you always like when other people recapitulate your work because it's really helpful because it means that you just didn't stumble upon, something in isolation. And so this has been welcome. John Weary's group at Penn and others have certainly found similar findings. Now, if you think about suppression of the immune system, it makes sense to use baricitinib to inhibit your STAT3. But one thing that gets me a little bit nervous is if you're paralyzed, do I want to make that worse? Because some therapies, if you give them at the wrong time, could actually lead you towards increased infections. And so one of the things that was coming out from the dexamethasone study, that made us very nervous because corticosteroids could actually make your immune paralysis worse as an anti-inflammatory agent. And so Monty Mazur, who relocated here to Case Western, did this really nice study in our LE spots. You're looking at control with dexamethasone, and we're going to come back to interleukin-7, but it's a therapy that improves interferon gamma production. And he looked at increasing the dose of dexamethasone against the amount of cells that are producing interferon gamma. And as the dose increases, you get worsened lymphocyte depletion and T-cell exhaustion. So in some patients, if you started with overwhelming cytokine production, this might be a good thing. But if you started at the wrong time point in your disease and gave steroids, say 2 weeks later, you may in fact make this person have increased risk for secondary infections because you're going to worsen their underlying immune suppression. And this paper was published in Critical Care Explorations this past year and really showed this in an ex vivo fashion about why it's important to really have a better way to figure out when to give therapies. So let's go back to sepsis for a moment. So if you looked at septic patients, this was published in Critical Care in 2013. And you can see here survivors versus non-survivors, adults and senior citizens. And those that had the highest lymphocyte counts lived, and those that had the lowest lymphocyte counts died. But what's most interesting is how many targeted therapies do we currently give in our ICU to our sepsis patients? 0. Everything is supportive care. So this is one of my other mentors, Peter Eihacker at the NIH, who conducted this, and you can see this forest plot. And what you're looking at here is different targeted therapies. Anti-TNF, soluble TNF, IL-1RA, PF, anti-prostaglandins, anti-bradykinin. Some of them were on the side of improving benefit, but they touched that line of 1 there. And in part, it's because it's not that the drug's not working. It's not that dexamethasone doesn't work in specific patients. But perhaps we're treating everyone as it's a one-size-fits-all. When my wife has a headache, she takes ibuprofen. When I have a headache, I take Tylenol. If we were doing a study at our house for ibuprofen, we'd have 50% efficacy. I don't know that it would make it to market. But I know darn well Tylenol works for my headaches and ibuprofen works for hers. But if the study was just called headache, probably wouldn't have any therapies. That's what we've done to sepsis. We've had to take a heterogeneous group of immune and hemostasis coagulation disorders, put them under one syndrome, and then conducted a number of studies assuming that one size fits all. And that's probably not the best way to actually evaluate targeted therapies. And so our group with Cincinnati, University of Washington, Case Western here, now at WashU, is doing a current immune endotyping of patients with sepsis so that we can further refine what this disease is and then be able to go back and use some of these therapies. And we're using our LE-Spot platform as a way to get there. And so if you think about it, remember, you look at what the cells are responding to their positive control, and then you can modulate that and see what the therapy response is. And if you've got increased spots, you've increased the response. So if you're paralyzed, you would like to see that boosting of the immune system. If you're hyperinflammatory and have too many spots to begin with, and you can down-regulate or dampen that, then that therapy may be helpful. And we're using this to be able to use in patients. And so what we do is we take blood from a patient, we put it on our dish. We then put different therapies coded on the dish, which is what we're in development for. And then we look at the actual patient's response. And then someday we'll go back to the patient and give them the therapy that they're going to respond to. Because not only do they have different immune responses, but in COVID, you've got different clinical phenotypes. You've got a COVID high compliance and low compliance. ARDS, but yet we've been treating all of the patients as if they have one type of ARDS. They've got multiple different clinical phenotypes. So here's what we did in COVID. We said, why don't we try to look at some of the different therapies that are currently being used in our dish and perhaps even be able to approach patients with this. So what you're looking at here is one of our patients that we enrolled. And this is their positive control, CD3, CD28. We do everything in duplicate. And you can see here, there's like no cells. This person's not making any interferon gamma. This person was a 40-something-year-old gentleman who got intubated within the first 24 hours of arrival, had a mortality of about 80%. We exposed his cells to IL-7, interferon beta, interferon alpha, OX40, and a checkpoint inhibitor. And what you can see here is that across the board, only interleukin-7 really boosted that response. Let's look at this patient. Different patient, similar age group, high mortality, positive control, CD257 cells versus 262 making interferon gamma. IL-7 increased, it almost doubled his interferon gamma production, whereas these other therapies didn't work. So if you wanted to go back to this patient and give him a therapy that may actually boost his immune system to help him clear the virus, because he's got difficulties with his STAT3 signaling, that would be potentially the therapy that you might, in fact, embark upon. So let me take you through what we did, because we did that.
For tonight, Emma Hogue hears from a St. Louis area officer who has survived the virus after being very close to death, and it's all thanks to an emergency treatment done right here in St. Louis.
Every day, I get better and better. My voice today is better than it was yesterday. I can walk further today than before I could yesterday.
Each day, Ryan Getz finds life looking up from lows in February. The police officer at St. Louis Community College and father of two tested positive for COVID-19 in late January. As Ryan's oxygen levels rapidly...
Where'd it go?
For tonight, Emma Hogue hears from a St. Louis area officer who has survived the virus after being very close to death.
And better. My voice today, walk further today than before I could yesterday.
Each day, Ryan Getz finds life looking up from lows in February. The police officer at St. Louis Community College and father of two tested positive for COVID-19 in late January. As Ryan's oxygen levels rapidly declined, doctors gave him a slim chance of surviving. Ryan's wife, Tara, took this screenshot just moments before he was put on a ventilator.
That was extremely difficult. I mean, it was extremely difficult to fight, fear. You don't want your mind to go there. You want to be, you want to stay strong.
I remember asking, am I going to be taking off the ventilator? And they wouldn't give me an answer, of course.
Ryan needed a miracle.
Everything that I knew at that moment was that this young man was likely going to die.
As a last-ditch effort, Dr. Kenneth Remy's medical team at MOBAP got FDA approval for a drug called interleukin-7. The antiviral agent increases white blood cells to fight off infection. It worked, and within hours, this chart shows how Ryan's cell count soared with every dose.
His lungs started to improve, his oxygen levels got better. Eventually, Ryan became Ryan.
It's just amazing. To be able to have that medicine offered to me and to bring me back from where I was at, it's just, words can't even say it. I mean, it's just awesome.
Tonight, Getz is back home, regaining his strength, surrounded by the ones he loves most.
There's too many people that we've lost this past year.
So as you can see, using a precision medicine approach worked for this gentleman, and we used it. If we would have he was getting actually a lot of the other therapies, but they were not going to be effective for him because he was so exhausted in his underlying immune system. So what is IL-7? It's a therapy that increases the number of viral-specific T cells, decreases viral load in other viruses like JC virus, CMV, hepatitis C, EBV. And it's been life-saving. We've used it, at least in evaluation in septic shock patients, where we were able to give a high dose and low dose, and you can see in blue and red, those are the doses of IL-7 versus placebo, and this is absolute lymphocyte count over time. Certainly the drug does that. It improves your lymphocyte count. It also improves your CD4 and CD8 T cells. So we thought, well, it's probably reasonable for us to embark upon a COVID-19 IL-7 study. And so that's exactly what we thought, because we could help eradicate the virus if you actually had circulating lymphocytes that could help eradicate this and avoid secondary bacterial infections. So then in 2020, we conducted a compassionate trial because everyone was telling us, hold on, this is the disease of Cytokine Storm. Are you crazy? You're going to give interleukin-7 to these patients that are on fire right now? And, you know, it was almost like we did not go through the last 50 years of sepsis where we've seen these divergent pathways and different immune phenotypes in different people. So we had to demonstrate first that we weren't going to kill people with this drug. And so we did that. We did this and conducted it in the UK. And here what you're seeing is in yellow is IL-7 over time. The lymphocytes increase as compared to those that did not get IL-7. Furthermore, you can see that we did not induce hyperthermia, so they didn't get a fever. And furthermore, their PF ratios didn't get worse, so we did not induce a worsened cytokine storm. And in fact, there may have been a better survival. So then from that point, we decided to do a randomized control trial, which is ongoing. And I'm proud to say that UH will be one of the sites in a couple weeks. And so this data is ongoing. I can tell you at the midterm analysis, the study is continuing. That's a good sign. So we're hopeful. So this is just a gratuitous way for me to show you that I've been on funny good stations with things that I've done. But more importantly, IL-7 is ongoing. But we're developing endotypes. Precision medicine is going to be the way that we take care of every patient, not this one size fits all. And then fortunately, I've been able to do some work with hemolysis in COVID with papers that are hopefully going to be coming out, which demonstrate how you can decipher the patients that have coagulopathy versus prothrombotic phenotypes against those that have increases in hemolysis based off strain. But there is a silver lining. So last May until this fall, I went back to those early questions, and it seems so far away, but my work in heme is actually my passion. And so we started to go into those signaling pathways, and we've now unearthed signaling pathways that explain the work in hemolysis separate from COVID, and I'm excited to go forth with that. So this is, as I've relocated here, my laboratory team. We'll be understanding host immune responses in sepsis, COVID, ARDS, sickle cell, malaria, and other diseases of hemolysis. We're partnering our host immune responses and our heme immune interactions. We're developing new ways to evaluate these disease signaling pathways using a bench to bedside and backwards to develop therapeutics, and to really develop precision medicine therapies to go back to patients after seeing this at the bench. So you see Monty Mazur, who came from WashU, Olivia Goodings, most of you know, Jason Clayton. You see one of your co-med peds residents here, Daniel Chen and Rebel Tariq, and our lab is continuing to grow, and I'm excited about what we're going to be able to do. So just a couple slides in summary, and then I'm going to summarize with something unrelated to this. When a pandemic hits, you need to alter your research, but don't forget the lessons that you've learned in previous pandemics and diseases such as sepsis. So I was fortunate. I learned this because I was at the NIH, and Chuck and Tony and all those folks that were my mentors there. When Ebola happened, I went and took care of patients with Ebola. I put my research on hold for the moment to do that. You've got to do that, but you've got to not forget the lessons that you had with those underlying research studies that you were doing, like in sepsis. SARS-CoV-2 is complicated, provides a heterogeneous set of endotypes, profound immune exhaustion, and a subset that endures a storm of cytokinemia with potentially different clinical phenotypes. We need to figure out those endotypes to tailor our therapies so that we don't continue with a one-size-fits-all. Of course, wash your hands, wear a mask. And then probably the most important thing now that I've taken care of over 2,000 patients with COVID, you've got to discover humanity during a disease that wreaks havoc on your immunity and wreaks havoc upon humanity. And so I would just say that the most important thing you can do when you see a patient with COVID is go in there and talk to them. I know it's so easy to just not have to mask up and put a gown on, but folks are bored and isolated. And one of the common things I've heard from patients that are on BiPAP for weeks on end is, I'm just isolated and lonely. I think I just am going to die. And sometimes they just need you to go in there and talk with them. See, these are some of my collaborators in funding. I'm going to go to one more slide. This is my family. Got 4 kids who endured me going to work every day and taking 4 baths and showers a day and taking care of all those patients. But this is my take-home lesson separate from the laboratory. Patients with COVID are different than we've seen before. Be patient with them. Sometimes it means that somebody you think is going to die, they will die if you stop all your therapies. But sometimes we just have to watch the grass grow. The biggest thing that helps them get through these really bad ARDSs is time. Their lungs need to recover. And if we don't give them that time, they won't get there. And obviously, very importantly, I'm encouraging always vaccination. But just to underscore this point about time, I'm going to show you another video. It's not there. Where's it at? Right there? Yes. Oh, sorry. It's okay, we'll go there. We're gonna show this one. 10 months.
Louis Estrada is thankful to be alive today.
I want to thank everybody. Thank you for coming out.
This homecoming was an uncertain one for months. Louis contracted COVID-19 in January. He says he was unvaccinated.
I had no underlying conditions. I was fine. I was walking over 10,000 steps a day due to my job, and I figured I'd beat it. But it whooped me.
COVID-19 led to pneumonia and hospitalization. His conditions and symptoms worsened over time. One of his lungs collapsed in the middle of the night, and he required a breathing tube. The virus wreaked havoc on Louis' lungs. He developed air leaks, which required doctors to install valves in his lungs.
Amen.
Amen. Louis' wife, Debbie, says the virus took a physical toll on her husband and an emotional one on her.
Doctors telling me that, he's going to be on a ventilator for the rest of his life. He's not going to be able to eat. He's not going to be able to do anything. He's going to be in a nursing home for the rest of his life, and just not giving me any hope.
Debbie says she had to search for sources of hope. Through friends and research, she got in touch with a specialist in Cleveland who had experience in the field and provided guidance.
Ken Remy gave me all the hope. He just kept telling me over and over again, it's going to take time. His lungs will heal.
Dr. Kenneth Remy says he's seen around 2,000 COVID-19 patients. Some survived and others didn't.
I'm happy that I was able to play a part in him.
I don't need to see myself. So the point I'm trying to make there is sometimes things take time. We've got to think outside the box. We've got to find precision medicine ways to treat our patients. They're not all the same. They all look different. They all have different immune systems. And at the end of the day, sometimes we just need to be patient with recoveries. And at the end, I think that if we do that and we provide some moniker of humanity to both our coworkers and to our patients, we'll succeed through this pandemic and see the end of it. Thank you.
Thanks. We have a big audience, and people can do questions verbally or put questions in the chat. It's really awesome, as Dr. Wiseman says. Maybe I'll just start out. The patient you gave the IL-7 to was not in a trial, right? That was kind of a compassionate use, or?
Correct. So we were able to get FDA approval for expanded access compassionate use for certain patients at that time. And then currently with our ongoing clinical trials, people meet outside of those restrictions. We're able to use the drug if we think that there's a potential benefit for those patients that are nearing the end of their lives. We've given it now to a number of patients.
I just want to say the clinical trial was probably key here. I remember early in the pandemic, there was a patient in the MICU when tocilizumab was experimental, and the ID team at that time and the NICU team tried to convince the patient and family they should take tocilizumab. And the patient family ultimately said, no, we're not going to take it. And the next day, the patient was remarkably better. So if you'd taken tocilizumab, I think the treating team probably said, wow, that medicine's awesome. So I think it did help your patient, right? But there's a risk of drawing a conclusion from one patient. That's why we need trials, right? So
100% agree, 1000% agree. If you give a patient a drug on a day that we have a lunar eclipse and the patient gets better, was it the lunar eclipse or the drug, or probably nothing related to those things? We need rigorous clinical trials. We also need to move away, I think, in the future from the way that we conduct our clinical trials. one might argue that a functional immune readout way to randomize rather than just saying everyone has the same disease might derive us a benefit going forward where we could evaluate a panel of different therapies rather than just isolated therapies. Tocilizumab in the right patients works. In the wrong patient, it could have deleterious effects, just like IL-7, just like steroids.
Well, the precision medicine is awesome. Well, thanks. Thanks for really fantastic talk and all the care of all the COVID patients. Incredible.
Excellent. Thank you. Are there any?
Alvin, this is Alvin Schmeier. Can I ask a question?
Of course, Dr. Schmeier.
Yeah, so it was a great talk, Ken. Thank you very much. I'm really intrigued by the lymphopenia, which we've all recognized in COVID patients, and I'm wondering if you've described things going on in plasma samples or whatnot, but have you done anything to take an unbiased point of view, such as on tissue and RNA-seq, or a proteomic approach, which is, we used to call that fishing expedition, but now it's an unbiased point of view, and occasionally yields insight.
Absolutely. That's the whole reason why when we, so you'll notice that when I presented it, we presented our descriptive findings with ELISpot separate from our findings with RNA sequencing, separate from our findings with the proteomic evaluation. And interestingly, is all three of those studies all came up with the same conclusions. And so I wholeheartedly agree. To use an unbiased, we did different groups at different locations to be able to evaluate this, and everyone came up with the same conclusions.
Okay.
It's a great, and I think both yours and Keith's points, compassionate use or going in and believing something is going to work and then seeing it happen doesn't mean that you can't go in biased. You have to be unbiased. You have to search for truth, because that's the only thing that's going to help patients, not what you want to happen, but how you can best find the answers to help those patients.
In your studies in the influence of heme, and really all the components of hemoglobin degradation, because we see interactions at the level of transferrin. Our main modulator in inflammation and hematology is really hepcidin. And have you done anything in relationship to your blood transfusion models, looking at the influence of hepcidin, or where, if it's in the equation?
Oh, absolutely. The short answer is yes. Long answer is we've looked and we have data that will hopefully come out in a paper looking at hepcidin, ferroportin expression, CD163, CD91 signaling, and a whole host of things that you're referring to. That's currently pending in our sepsis animals as well as our human studies. Great question, though. You and I definitely need coffee and a drink.
Anytime. Thank you.
There's a
I think we'll take one last question.
Go ahead, Rahul.
We'll take one last question from Dr. Siddhigam. So could you envision any role for Hemopexan in conditions of sterile inflammation like autoimmune diseases or post-bypass surgery inflammatory syndrome?
Yeah, that's a great question. I think first you need to characterize to make sure that you've got something that you're going to scavenge. So I think it's important in certain diseases to first delineate that there is intravascular hemolysis in a fashion that's partitioning itself with certain mediators that are causing deleterious effects. So yes, I could foresee that, absolutely. I think that there's a role certainly in some folks are looking in haptoglobin use for sickle cell. Hemopexan, Shaw Warren at MGH has looked at some other diseases going forward. But yeah, short answer is yes, and I'm hoping actually we can develop this trial to do this. It's a great question.
Well, thank you again, Dr. Remy. That was an excellent presentation. Really appreciate you taking the time. Thank you.
Thank you.